Hey coders, Harshal here from Decode Healthcare. Welcome to this high-yield explainer where we're going to totally decode the exact rules, timelines, and requirements for transitional care management. Our goal today is to keep your billing incredibly accurate and, most importantly, audit-proof. Look, if you're dealing with patients who are moving from a hospital setting back to their homes, mastering the 99495 and 99496 CPT codes is absolutely essential. So let's dive right into this and make sure you never leave well-deserved revenue on the table or worse, open yourself up to compliance risks.
Here's the blueprint for our explainer today. We're covering 1. TCM scope and purpose, 2. the 3 mandatory TCM components, 3. coding 99495 versus 99496, 4. billing rules and timelines, and 5. compliance and audit guardrails. All right, let's jump right into section 1, TCM scope and purpose. Think of TCM as a bridge over a highly vulnerable gap. The exact moment a patient leaves an inpatient hospital setting, a skilled nursing facility, rehab, or even observation status, and returns to a community setting like their home or assisted living, their risk of relapse just skyrockets. Our core clinical objective here, and Medicare's goal too, by the way, is stopping that 30-day bounce back to the ER. We do this by ensuring structured care continuity. To qualify for this 30-day care management service, the patient's medical or psychosocial problems must require at least a moderate to high level of medical decision-making during this critical transition period.
Moving on to section 2, the 3 mandatory TCM components. So, these are the 3 pillars of TCM. If you miss even one, the whole structure collapses. Step 1 is an initial direct contact within 2 business days of discharge. This could be face-to-face, telephonic, or electronic communication with the patient or their caregiver. And here's a pro tip for you. If you literally can't reach them, you have to document at least 2 separate, timely but unsuccessful contact attempts to still qualify. Step 2 involves comprehensive non-face-to-face care coordination. Finally, step 3 is the mandatory face-to-face visit. Now remember, this visit is entirely bundled into the TCM code itself, meaning you cannot bill it separately as a standard EM visit. Now, the sheer volume of non-face-to-face work captured under these codes is just massive. Clinical staff coordinate care and community services, communicate with home health agencies, and educate the patient to really support self-management. The provider is busy obtaining and reviewing discharge summaries and managing any follow-up on pending diagnostic tests. But crucially, and believe me, auditors aggressively look for this, medication reconciliation and management must occur no later than the date of the face-to-face visit. It is an absolute requirement, no exceptions. Okay, section 3, coding 99495 versus 99496. Let's figure out how to choose the right code. So choosing the correct code really comes down to a dual pivot point: medical decision-making and time. CPT 99495 gives you a 14-day window for that face-to-face visit, provided the MDM is of at least moderate complexity. CPT 99496, on the other hand, shrinks that window down to just 7 days because you're dealing with a highly complex patient requiring high MDM. Both of these elements have to align perfectly for you to select the right code. Notice how these 2 variables interact here. For 99496, you absolutely need high MDM and a visit within 7 days. But what happens if your highly complex patient misses that strict 7-day window and you end up seeing them on, say, day 10? Well, you're always bound by the strictest of the 2 criteria. That means you have to drop down and report 99495 instead, simply because day 10 falls into that 8 to 14-day window. Make sense? Next up, section 4, billing rules and timelines. Let's treat this like a ticking clock over a 30-day timeline. The period commences exactly on the date of discharge, that's day 1, and it continues for the next 29 days. Within the first 2 business days, you must initiate that interactive communication. By day 7, if you're targeting 99496, that face-to-face visit has to be completed. For 99495, you have until day 14. And remember, across this entire 30-day period, only a single billable TCM service can be reported. Now, when it comes to putting a date of service on your claim form, Medicare actually requires you to use the 30th day post-discharge, while some commercial payers might want the date of the face-to-face visit, so you've got to always double-check your payer policies. What about the specific billing nuances? Well, only one individual may report these services once per patient within that 30-day window. You absolutely cannot report another TCM for a subsequent discharge if the patient bounces back to the hospital, which is a coder's worst nightmare, right? And then is discharged again within that exact same 30 days. Now, the same individual can report hospital discharge day management and TCM, but the discharge service itself does not count as your required TCM face-to-face visit. And importantly, if a readmission does happen within those 30 days, or if you just fail to meet all three criteria, you can't bill TCM. Instead, you'll need to convert that face-to-face visit into a standard EM code like a 99214 or 99215. Finally, Section 5, Compliance and Audit Guardrails. Let's talk about how to protect your practice. This is exactly where the auditor steps in, basically hunting for pure documentation errors to claw back revenue. First off, ensure you never report TCM services provided in the post-operative period of a service that you individually reported. You simply cannot double dip on global surgical packages. Also, TCM cannot be billed concurrently with chronic care management, principal care management, or remote patient monitoring by the same provider. To build your compliance shield, ensure you clearly document the timing of your initial 2-day communication, always verify medication reconciliation happened on or before the face-to-face visit, and meticulously back up those MDM levels. The CPT guidelines are literally unforgiving here, as they state their documentation must clearly outline the timing of that initial post-discharge communication, the exact date of the face-to-face visit, and the verified level of medical decision-making. Missing just one of these documented elements means your TCM claim is incomplete and for sure won't survive an auditor's review. Go review your templates today and make sure every single one of these data points is a hard stop before the claim goes out the door. When done correctly, transitional care management not only supports way better patient outcomes and prevents readmissions, but it appropriately reimburses you for the heavy lifting of care coordination. You just need to ensure your timelines are locked in, your MDM is completely accurate, and your documentation tells the whole story. So ask yourself right now, is your practice's documentation leaking well-deserved TCM revenue right under your nose? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.